My name is Meagan Costedio, and I'm the Medical Director of Colorectal Surgery at University Hospital's Ahuja Medical Center in Cleveland, Ohio. I'd like to thank the committee for including me tonight in the program, and I'll be speaking tonight on help my rectum is falling out, what to do about rectal prolapse. I have nothing to disclose. On examination, oftentimes patients will come in with significant complaints, but when you place them in the Kraske position, you won't be able to see the prolapse. So you may need to take the patient to the toilet and have them strain, particularly in mucosal prolapse. Office proctoscopy may show anterior rectal ulcers 10 to 15% of the time, consistent with solitary rectal ulcer syndrome, which can help diagnose the problem and or can help in diagnosing internal intussusception. And we need to ask about urinary incontinence or other symptoms of vaginal or uterine prolapse and examine the vagina to make sure there's not other organ prolapse occurring. Full thickness prolapse appears with concentric rings, as you can see here on the left, and mucosal prolapse is more radial rings, and that can help guide our operations. So the workup may include nothing. If you have an elderly patient who has full thickness obvious prolapse and has already had a colonoscopy, you may proceed directly with surgery if they have no other symptoms. But if you can't tell if the patient has prolapse, fluoroscopy or defecography can be very helpful, and MR defecography can be helpful in diagnosing all different compartments of the pelvis, particularly in combined procedures. A colonoscopy can be helpful to evaluate your sigmoid if you're thinking about possibly a resection, and of course making sure there's no cancers or polyps. Barium enemas can be helpful, and anal manometry can be helpful in pelvic floor dysfunction, but only if the prolapse is reducible. So if a patient comes in with acutely incarcerated or strangulated rectum, we need to listen to Def Leppard, pour some sugar on it. Sugar can help decrease the edema in the wall of the bowel. Oftentimes some direct pressure, so squeezing on the prolapse. If the patient might need pain medications or relaxant medications to help with this, and then you push into the opening of the anus, and oftentimes you can get things reduced. For patients who are unable or unwilling to have a surgery for prolapse, you can teach them the sugar trick. They can use a high fiber diet and or use laxatives to help minimize their constipation. Discuss preventing straining, and they can use tricyclic antidepressants for tenesmus. Interestingly, pelvic floor physical therapy or biofeedback is not helpful if you do not fix the prolapse. This is something that you may never see. It's pretty rare in acutely strangulated prolapse because the pathophysiology of prolapse is oftentimes a very lax pelvic floor, which leads to the fact that they oftentimes will not get strangulated. But if this does happen, the treatment is an urgent or emergent Altmaier with diverting loop ileostomy, so a perineal proctosigmoidectomy. And you have to remember that there'll be significant venous congestion in this with significant bleeding, so you may want to have a vessel sealing device available, or at least stitches. When you get to the normal sigmoid, remember the anal mucosa is not normal, and so oftentimes protecting diverted loop ileostomy can prevent a coloanal leak. So surgical options for run-of-the-mill non-emergent prolapse are grouped into two groups, perineal and abdominal. The perineal options are thought to have a higher recurrence rate, but decreased comorbidity as they can be performed with spinal. And that includes the Delorme, which is a mucosectomy with muscular pexy, or an Altmaier, which is a perineal proctosigmoidectomy. A third procedure, which is the anal encirclement or the Thiersch procedure, is largely out of favor and does not work. The abdominal options, which offer in theory a lower recurrence, but potentially an increased comorbidity with general anesthesia, include a posterior rectopexy with or without resection if the patient has constipation, or a ventral mesh rectopexy, which is the newest option and is largely in favor right now. The mesh procedures, which included the Ripstein or the Wells procedure, are largely out of favor due to mesh complications. Do keep in mind that the median survival of a patient over 90 after a perineal procedure for prolapse is more than 4 years. So once you make it to 90, you will likely live longer, and so we need to make sure that we're doing the most long-standing procedure for these patients. So the Delorme procedure, which is the mucosectomy, is oftentimes for patients with mucosal prolapse or a less than 5 centimeter full thickness prolapse. It has a documented 10 to 40% recurrence rate, but does have a good effect on quality of life compared to abdominal and the Altmaier procedure. And you can see here they remove the mucosa and then pexy or plicate the muscle and then perform and re-sew the mucosa back together here, which can be helpful with continence in theory. The Altmaier, or the perineal proctus sigmoidectomy, you 2 centimeters distal to the dentate line, you cut through the rectum, and then you're able to pull the sigmoid out through the anus. You can perform a levadoroplasty if the patient has fecal incontinence, and then you perform a hand-sewn coloanal anastomosis from the sigmoid to the anal mucosa. There's a 16 to 30% recurrence, but also good quality of life after this procedure despite a coloanal anastomosis. The abdominal procedure we're going to talk about first is the oldest, or the posterior suture rectopexy, where you dissect the right peritoneum of the rectum. You dissect the mesorectum from the presacral fascia, and you take off the right peritoneal reflection and the anterior peritoneal reflection. You dissect the rectum from the posterior vagina. I do like to leave the lateral attachments intact to preserve nerves. And then you pull the peritoneum of the prolapse and suture it to the sacral promontory. And this procedure has been performed for a long time and can be performed in conjunction with the sigmoid resection, particularly if the patient suffers from severe constipation. The PROSPER trial looked at Altmaier and DeLorme's versus resection rectopexy and suture rectopexy, and then compared the abdominal versus the perineal procedures for recurrence. And interestingly, over 5 years, the recurrence was exactly the same between the perineal and the abdominal procedures. Now, again, this only included rectopexy. It did not include the ventral mesh rectopexy. Interestingly, that quality of life and recurrence data was the same between the abdominal and the perineal procedures. Ventral mesh rectopexy is the newest procedure described, where you cut through the right peritoneum around the rectum. You then dissect the rectum from the posterior aspect of the vagina down to the perineal body and suture a mesh to the perineal body as well as to the anterior rectum, and suture the other end of the mesh to the sacral promontory. And then you close the peritoneum over this so that the mesh is excluded from the peritoneal cavity. In the largest study right now, 790 patients, follow-up was not quite 3 years. There was a 10-year estimated recurrence rate of 14.3%. Again, this was less than 3 years, so we don't have a true recurrence rate. The mesh erosion estimated was about 1.3%, but it showed a significant improvement in incontinence as well as outlet obstruction. The mesh complications were about 4%, and that's the biggest criticism of the ventral mesh rectopexy is the mesh issues. As we know, there are currently, every time you turn the television, you can see a mesh litigation ad. It does seem to improve sexual function for patients. And then we tried using biologic meshes, considering the mesh concerns. But when we looked at biologic versus synthetics, the recurrence rate's about the same. Again, this is very short-term follow-up. And the mesh complications were low enough in the synthetic group that they did not see a value to the biologic mesh due to the costs. Robotic rectopexy, of course, is done, and if you know how to already use the robot, then likely your learning curve is even lower, but it does take about 18 cases to get to your average drop in operative time. So if you're not doing these cases often, it may not be worthwhile picking up new technologies to help you. So in conclusion, the workup for pelvic organ prolapse should include the uterus and vagina and bladder as well, that all prolapse procedures have complications and issues with recurrence, that once you fix the prolapse, the patient's quality of life improves no matter how you do it. And the right operation is the one that both the patient and the surgeons feel the most comfortable with. Thank you very much for your kind attention.